ദിവസമാണ്. ഞങ്ങളതിൽ സന്തോഷിക്കുന്നു. ഇന്ന് ഞങ്ങളോട് ഇടപെടണമേ. പ്രത്യേകിച്ച് അവിടുത്തെ ദാസനായിട്ടുള്ള ഡോക്ടർ തോമസ് ചാക്കോയുടെ കൂടെ ഇരുന്ന് അദ്ദേഹം സംസാരിക്കുവാൻ പോകുന്ന കാര്യങ്ങൾ മനസ്സിലാക്കുകയും അതനുസരിച്ച് മുൻപോട്ടുള്ള ഞങ്ങളുടെ പ്രയാണത്തിൽ അത് ഞങ്ങളുടെ ഇൻസ്റ്റിറ്റ്യൂഷനും ഞങ്ങളുടെ പേഴ്സണൽ ലൈഫിനും വലിയൊരു അനുഗ്രഹമാക്കി തീർക്കുവാൻ സഹായിക്കണമെന്ന് പ്രാർത്ഥിക്കുന്നു. ഇന്ന് വന്നു ചേർന്നിരിക്കുന്നവരും വരാൻ ആഗ്രഹിക്കുന്ന എല്ലാവരെയും ഒരുമിച്ച് കൂട്ടിക്കൊണ്ടുവന്ന് ഇത് ഞങ്ങൾക്കും ഞങ്ങളുടെ ഇൻസ്റ്റിറ്റ്യൂഷനും വീണ്ടും വലിയൊരു അനുഗ്രഹവും അതിനുശേഷം മറ്റുള്ളവർക്ക്, ഞങ്ങളുടെ ദേശത്തിന്, ഞങ്ങളുടെ രാജ്യത്തിന്, ഹ്യൂമൻ ബീയിങ്സിന് അതൊരു വലിയ അനുഗ്രഹമാക്കി തീർക്കുവാൻ സഹായിക്കണമേ. വീണ്ടും ഞങ്ങളെ ഒരുമിച്ച് കൂട്ടിയതിന് വേണ്ടി നന്ദി. കർത്താവായ യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Today we have an international speaker in our midst, and it's a great privilege that we have with him, an erudite scholar and a medical educationist par excellence. He is currently the senior professor in community medicine and also is the dean of medical education, mentoring most of our faculty. He is a teacher of teachers. He was awarded the International Fellowship in Medical Education, IFME, in 2002, which he completed with distinction at the Department of Medical Education, University of Illinois at Chicago, and the 2-year Educational Leadership Fellowship at the Famer Institute at Philadelphia by the Foundation for Advancement of International Medical Education Research, FAMER, and was subsequently invited to serve as the Global Faculty Advisor for the Famer Institute program in Philadelphia. Especially people like us were benefited, him being teacher at FAMER. He was the founder director 2007 to 22 of the PSG FAMER Regional Institute that administers the 2-year FAMER Institute Fellowship Program for faculty in medical schools in the South Asia region. He was also the Secretary General of World Federation for Medical Education, WFME, Southeast Asia Regional Association for Medical Education, CRAM, for 6 years, 2011 to 17, and the President of the Academy of Health Professional Educators, India. He is often invited to be member of the WHO expert committees to recommend improvement in teaching of public health in the Southeast Asia region and transformative training of healthcare providers for primary health care within health systems. He has also been invited to conduct tailor-made workshops for capacity building of health professionals and educators in several national and international conferences. His areas of interest in medical education include curriculum planning, program evaluation, competency-based and community-based medical education, and educational change management towards improving teaching in medical schools and improving global standards in medical education. He was recognized by MU India, a network of 30,000 healthcare educators, with the Lifetime Achievement Award in 2022 for his contributions to health professionals' educations in medical education. We all, as medical students back in the early 2000s, we looked at him with awe. Sir is my teacher at PSG Medical College, Coimbatore. We looked at him with awe. A very handsome, stately professor of community medicine, erudite scholar back in the day itself. And it's a great privilege to have him with us. Can we put our hands together and welcome the one and only Professor Dr. Thomas Chacko, sir.
Thank you. Thank you, Jacob, for those words of introduction. I see mostly students had prepared this presentation for faculty members. As usual, faculty are busy. So the topic given to me was achieving excellence, which is institutional excellence through education research guided educational intervention. So it's an interesting topic, and the tagline added to it was that I present the global perspective so that what the world thinks and what is the thought process across the world gets disseminated locally. This is a very familiar picture. Us students, when we were students, naughty students and all those things, when the teacher was taking class in front and talking to the blackboard rather than facing the students. So arrows were shot. And so to overcome this, the innovation was, as you see here, rear view, and you could catch the naughty fellows. Yeah, so basically, we are as an institution having several concerns and challenges. One is the excellence and quality requirement. Bcmch must have excellence so that the students choose Bcmch as the college of first choice. In this world, with changing world and the 21st century skills requirements, they are changing, and there are external challenges, like, for example, yesterday's Times of India said 170 more medical colleges. I don't know from where the faculty for those 170 more medical colleges will come. So those are external changes and challenges. And as a result of these problems, we have to design innovations. And when we design innovations, we have to do research to back the evidence or produce the evidence that these interventions do actually work and benefit the students. Students are the bottom line, the beneficiaries. And as a result of this research-guided educational interventions, the institution becomes a center of excellence. So this is the brief summary. Reasons for innovations, why innovations happen, and what are some of the good practices in medical education across the world that we could borrow from. As a result of that, we could adopt some of those innovations here. And one of the things is about asking the right research question and use of conceptual frameworks. I will be giving examples for different situations. And I always tell my fellows, whatever little you are doing, do it the right way, so that when you do it the right way, it gets published. So generally we do it our own way, but it has to be accepted by peers outside the institution where it was done. And so it has to be done the right way or the scholarly way. The entire presentation is about educational research guided institutional excellence. So since students are there and I'm familiar with them, you're free to ask questions, because what the slides I have may be little too much for you. But by asking the question, it will generate interaction, and as a result of interaction, many more students and faculty would be benefited. So I encourage you. So one of the reasons why we have innovations in medical education is the curricular reforms, the new curriculum, of which you are the part from 2019 batch onwards. Neither we underwent the curriculum, CBME curriculum, nor did our teachers, and so it's totally new. We are treading the untrodden pathway. So you are all pioneers. We are also pioneer teachers teaching this new methodology. And so many of the methods that are being introduced, they are new. And so we teachers have to think, are they effective? in application of knowledge, development of skills and competencies, and whether we are using objective methods of assessment. Most of us still follow the old methods of assessment which checks knowledge, but the curriculum now is competency based. The other thing that the reason for innovation is ranking of colleges, and usually a rough way of ranking is done by opinion survey and things like that. There is no evidence to back. It's just people's opinion. So how do we contribute to opinion making or opinion building? It's only through research and publications. So when what we do as research gets published, then our peers, our faculty outside the local institution get to know what all Believers Church Medical College is doing, what innovative approaches and methods it is following. Then the other reason for innovation is program evaluation. As part of quality improvement, we are required to collect feedback from the students, and we have to do survey, and we have to get information from the students. So now the students, since you are here, this is to explain how the information that is collected from you goes into curricular replanning. So the teachers and the curriculum committee sits and it deliberates on the inputs that you are giving, so that we can try to overcome some of the bottlenecks. And obviously there are some student problems in learning, difficulty in learning, and so leading to almost some of them have dropouts. They drop out of the medical college, and it's a loss to them, their parents, to the institution. And so it is important to know, and we in medical education and the institution need to identify the reason for that. Why students are not able to learn, why are they not able to cope up, and why are they failing. In the current assessment system, it is such that it is very difficult to fail, but still some of them are failing. So obviously those who fail, there is obviously something wrong within the system. And so we need to address those by better methods of teaching and assessment. I was talking about the competition and the pressure to be recognized by parents and students as the institution of first choice, so quality assurance of achievements, institutional goals and objectives, the pressure of continuing quality improvement. Unless we improve, we will be left behind. And with 170 new medical college being added this year, you can imagine those that are not producing the results, and the students that come out of many of these institutions don't get PG seats, they don't clear the All India exams. It's an indicator of something is wrong, and we need to address those. So role of educational research and program evaluation is to verify against standards. What are the standards? And check whether the inputs, the processes, the outcomes are achieved through educational research. So research-guided evidence based on which decisions are taken. And so this plan, PDCA cycle or PDSA cycle is plan, do, study, and analyze or apply. So we need to move from the present state, which most of us are happy about it, but then through continuous quality improvement, we need to become better and the institution of first choice. So this is and the critical thing is, so we need to innovate. So just the name innovation is not enough. We have to do it in a systematic way. So let us see what are the good practices that have come into force elsewhere. If to give a simple example, until recently we had the most popular car in India, the Ambassador car. And if you open the bonnet of the Ambassador car, there is nothing inside. Now, if you see one of the modern cars, it's full of various machines apart from the engine and so many things. So anything goes wrong with the modern cars, you cannot rectify. Whereas the Ambassador, anybody on the roadside can fix it. And many of these international good practices abroad, they started doing the research and program evaluation. And as a result of that, since the Indian curriculum was adopted from the British, and British gave up the curriculum, and as well as their Vauxhall car, which was the father or mother of the Ambassador car, 50 years back. And we are still driving. Of course, we have moved from Ambassador to the modern hybrid and EV and Tesla and all those things. But the reason why progress and reforms are not happening is because we fail to do education research. And as a result, but recently, due to various awareness being generated about research and the capacity building for education research, a lot of things are happening, and it is now mandatory as part of the quality assurance program itself, the accreditation, that it has to be done. To begin with, it all starts with the right question and start with the problem identification. What is the problem in the existing system? Usually it is recommended by educational researchers, we start with the local problem. Say, for example, students are not attentive in your lecture hall. Okay, so it's a problem. Fortunately or unfortunately, this problem is not restricted only to Believers Church. It's a universal problem. So by addressing the problem, which is a local problem, and studying and doing research as to why we are not able to hold the attention of the students and engage the students, are we planning our lessons in an effective way, then it leads to solutions and innovations with evidence that it works. The change that happens, that we introduce works. So that change, when we submit a manuscript for publication, our peers outside our institution, they recognize the value of the innovative ways, the evidence-guided innovations that emerge. So one of the things, how do good research questions arise is through conceptual framework. Myself and Sangeeta, once she just strolled into my room and I was talking about conceptual frameworks, and suddenly she said, oh, I am working on hepatitis B and I want to do a survey. She showed me a questionnaire. I suggested, Sangeeta, why don't you look at the conceptual framework and see what questions in the questionnaire are missing and what is important. And like a very bright and enthusiastic faculty member, she went, did it, and only few months back it got published. And Sangeeta has done it the scholarly way. So I'm saying that so that many of you are enthused and use the knowledge that we have globally. So when we start from a local problem, the chances are that when we publish, the editor of the journal will throw it in the dustbin and say, this you publish in your local bulletin. because it's relevant to your institution, not to others. So we need to narrow the research question into a general, good, specific question, and that's why a conceptual framework helps. So my professor in UIC Chicago, Dr. Bordach, he was the editor of a journal, and he cited one of the commonest reasons why manuscripts get rejected is because there is no conceptual framework guiding the research. Because some kind of a survey is done without looking into the existing body of knowledge, which gets converted into a conceptual framework. So research guides development of a conceptual framework. And when we researchers look at the conceptual framework, we don't miss some of those things which are important to investigate the phenomenon under interest. For example, this is the conceptual framework about the problems in student learning. There are so many learners, background, curriculum, design, structure, what kind of curriculum, institution, instruction, how do the faculty teach, the materials given, the setting of the school workplace, what type of evaluation and feedback is achieved, and things like that. So any problem with the students, we have to look through the lens. See here, we have to look through the lens of a framework. And that will help us more chances of identifying the factors that are contributing locally. And so the findings will then be able to help us generate an intervention which addresses the problem. And then through educational research, we provide the evidence that the new intervention responding to the problem works and it is effective. So for example, here we did a study on, the problem was handicap in learning style of students. So some students learn visual learners, some are auditory learners, some learn by hearing, and each student has a handicap, and the type of sessions that are taken in the institution are fixed. So the innovation was discovering strategies that are already discovered or used by some of the students. Some of the students in the same institution with learning handicap have already on their own discovered how to overcome the handicap. Say for example, they can't mug up whole paragraphs. So they convert the paragraph into a concept map or a diagram, and then it is a picture. So they convert paragraphs into a picture and it remains and it works. So this secret was known only to few students, and through the process of appreciative inquiry, from the classroom, we elicited what are the various strategies that overcome. And as a result of that, they introduced or encouraged other students to also follow. And the research, after we did this intervention, we used research to generate the effectiveness, the evidence of effectiveness, and it got published. So this you must have become familiar. Early clinical exposure. Okay. So what's the problem? For which it is a solution. Students are not now motivated. Students get admission to a medical college. They come with dreams, and then suddenly they are in the anatomy class or dissection hall, and what passes through which foramen and all insertion, origin, and they get lost. They are not motivated. They start asking questions, why am I studying all this? So lack of motivation of the students, it's all new knowledge. So the innovation is early clinical exposure, so that when they go and see a case of, say, claw hand or wrist drop or any of those conditions, and then go and read anatomy, or the anatomy professor starts with the problem, the clinical problem, and then asks the students to read about it, and then there is a discussion in the class. So that is what is done, and then the study was done, and we generated the evidence that such a process was effective. Here is another of mine effort. Having been in charge of medical education in my earlier institution, our institution was celebrating 20 years of existence, and they wanted to plan 20 years ahead. So I used the technique of visioning, time travel. We have all read about time machine, time travel, and so we took the faculty members to go forward in time, think of the year 2030, what will you be doing, what will your children be doing, how will the students be learning, what methods of tools of learning they will be using in that year, and then ask themselves, are they prepared for that? Do they have the competencies and the skills to teach in ways in which the students will be learning 10 years from now? And so you are identifying the gap between current and the desired one, and it gives us time to plan a faculty development program. So visioning into the future, faculty capacity building to make them ready for 21st century skills. Making medical students as teachers. So for example, Elizabeth James madam comes to me and says, oh, we are short of hands, busy OP, where is the time to teach individual students? And then I gave the idea that why not use the students themselves? Design checklists, give it to them. The students use the checklist after an encounter and see what has been done, what remains to be done. And finally they practice. They become aware of the gaps, and then they practice. And ultimately, of course, the faculty have to validate whatever assessment using the checklist was done by the students themselves. So that is what is there in your current CBME logbook, which says 3 attempts, and each attempt may be initial attempt 1 and 2 could be by your colleague students or the junior or senior resident. And as a result of that, you get the feedback, they are available, individual attention is there. Also, we conduct a program called Residents as Teachers. The residents are there doing post-graduation. And when we encourage them, entrust them with teaching responsibility, when they teach, they learn, the residents learn. And the beneficiaries are the students. So this is another out-of-the-box kind of innovation that one of the faculty, professor of medicine in JSS Medical College, he came up with this idea, getting inspiration from Sherlock Holmes book. Critical thinking is what clinical reasoning skills is what was missing. And similarly, another education from JIPMA Pondicherry did realize that there is shortage of critical thinking skills, and a gap analysis was done, and as a result of that I could mentor them with what needs to be done, the conceptualizing of the intervention, planning, discussion, and ultimately scholarly writing, and it got published. Counseling skills. Now, we want our students, the Bcmch graduates, to be good, compassionate doctors who can communicate well. So, are we teaching them? And one of the ways here in JSS Medical College, Chandrasekhar, he's a public health dentist. He wanted the students to develop counseling skills for which they developed a module. The problem was the students did not have the ability to identify the lesions early, the changes due to tobacco use. And then the tough part is counseling those with patches inside their mouth, with counseling skills, so that the patient gives up the risky behavior. And since the curriculum is already so tight, so the next thing is a module, creation of module. Sangeeta again was interested in creating a module, because once we create a module, Riju also said that so many programs are there for staff development. Where is the time for the staff? Where is the time for the teachers? So why not develop a module? So module also requires a systematic process. One of the methods of module design is the ADDIE framework, analysis, design, and all, and evaluate. The framework itself guides you to design the module in a systematic way. So problem is that, and we use the systematic way, we do it in a scholarly way, and as a result of that, we generate evidence and it gets published. So violence against doctors is a very much real problem, especially in Kerala, where doctors have been stabbed or even killed. And so it's a very much a problem. And again, using an ADDIE framework this is a familiar picture, a local problem, lecture students, I mentioned this earlier, and it's possibly true, and generalizable research question could be, would lesson planning using Garnier's 9 events of instruction framework improve student engagement in retention and application of learning to improve problem solving? So there is a problem, and there is a intervention, and what is going to be measured, all that is captured in the research question. And so this is the framework. So when we plan our own lesson, the teachers must plan to gain attention. Then inform them about the objectives. It must be made clear. Check their prior learning or give them assignments, and then provide feedback, assess performance, and enhance retention. So this needs to be planned for instruction by the teacher for every session, be it as a practical session, clinical session. It's basically a lesson planning using this framework for any kind of instruction. And then you use educational research methods to evaluate your innovation or intervention. And it can be done by every faculty member to plan your session, that is called lesson planning. Then you deliver your lecture, and then at the end of the lecture, reflect. What went well? What is it that I could improve? And after a series of this planning, doing, and getting feedback from the students, some of those handicaps due to passive listening get eliminated. You become better. So lectures, the teaching in small groups is now the preferred method of instruction in the new curriculum. This is another important question that academic leaders have to address. Poor performance of an institution. Why there is poor performance? Why only 85% of the students pass in final MBBS, but only 25% have got all India PG admissions? So passing at the university level and the pass rate or admission at the PG level is the problem. And then maybe they are not trained well, and as a result of that, there is need to investigate. And the framework for investigation is the systems approach. It talks in terms of what is the input, what type of students and teachers and type of sessions are conducted, what is the process that the student undergoes, and the outcome and the feedback we receive. So that is why we have student feedback designed to elicit information about input processes and outcomes, so that decision can be taken to change either input process or output, so that we can produce the competent Indian medical graduate. So all that can be done using education research. Now, mastering of professional skills, the competencies. In our curriculum, we have certain certifiable skills and competencies. In each department, they are listed. It is part of the curriculum. But these certifiable skills, we must, at the MBBS level, we reach from novice to a competent or advanced learner, and then at the PG to a higher level. But suppose that these competencies are not being achieved, then the Erickson's model of deliberate practice, this is a conceptual framework, and these are the components of the framework. As educationists or educational researchers, we need to ask ourselves, is feedback being elicited? Are students being given chance for repetitive practice? Is there curriculum integration, range of difficulty level from novice to advanced to proficient, and all those things being documented? Multiple learning strategies, either in the simulators or real patients and case discussions, capture clinical variation, control environment, individual. So these are the components of the framework for mastery of performance. So if something goes wrong and students are not reaching the expected level, so something the teachers must look into these things and investigate, do research, and then based on the research, introduce an innovative method. So innovative intervention, then repeat study, and then when you do the intervention, obviously the problem for which the intervention was designed should go away. So this is another of our research that was done called the Competent Intern Program, use of peer feedback. Interns are going to the peripheral health centers. There is one medical officer. But if they continue without supervision, without receiving feedback from the medical officer who should be observing their patient encounter, if it is not happening, they will continue to develop a wrong practice. So what we did was we wanted to peer feedback. 2 or 3 interns are there. So when one intern is diagnosing and giving care to the patient, the other intern is observing using a checklist and guidelines which explains what each item in the checklist mean, or the criteria for completion of each of those criteria, based on which they can then tick mark or leave it. So peer feedback. So innovation, peer feedback, deliberate practice, and then finally at the end of the month or the posting, the faculty in charge validate or certify. Here is another conceptual framework, and you're conducting several CME programs, but you observe despite so many CMEs, the doctors have not changed in their own professional practice. So is it the problem with the doctors attending the CME, or the CME has not been properly designed. So a research educator will go through the activities, the teaching, the setting, the timing. Timing is also very important, because if the timing is not convenient for the attendees, their mind will be somewhere else. So the reasons why, and then the outcomes. So use of this framework. So this is a framework known as conceptual framework for CME CPD. So those were the examples of frameworks. And then I wanted to tell you and share about the systematic process. One of the systematic process of planning an innovation or an intervention is the logic model and the theory of change. So it's a series of if and then what. So forward program theory, for whatever you are trying to introduce. Program theory is to understand why you are introducing a particular activity in the innovation or intervention. And the logic model is to understand how it is to be implemented. I will explain. And then also, once we have this logic model and theory, it helps us to identify the indicators of effectiveness. So the benefits of using model is logically it connects through backward planning. You start with outcomes and then go to activities. And it ensures, so the idea is after it has been designed in a logical way from backward to activities, the benefit is when you implement those activities, it will definitely lead to the planned outcomes. Take example of the very popular Bcmch vision and mission statements, and we have to start preparing a logic model with the institution's vision, and in order that these outcomes of vision and mission statements are to be achieved, what are the outcomes and output needed, and based on each of those outputs, what are the activities needed. So being in the Department of Medical Education, our focus was on capacity building. So one of the inputs, critical inputs to achieve these outputs that lead to competent Indian medical graduate in Bcmch is to build capacity of the faculty, as well as so that the faculty are capable of implementing the interventions. So activities are derived, and then you plan and implement those activities. And then since we know what are the outputs and outcomes expected, we can measure the effectiveness of the innovation or the intervention. So finally, the point is about conceptual frameworks that guide institutional excellence. As an institution as a whole, the leaders in the institution, what are the frameworks that are available? One of them is the Baldrige Performance Excellence Framework. So these are the various components. So when we are planning activities and allocating resources, and we want excellence, and we want the staff and the faculty to perform as per to reach excellence level, are these components delivering? Customers in the case of medical college will be the students, and as a result of the students may be the patients. So this is just an example to show that conceptual frameworks are available for us to examine and investigate and do research. Another framework is for organizational intelligence, and tells about strategic objectives, best practices, innovation capability, and all the leadership, culture in the organization. Are the employees given support? Are there mechanisms that support financially as well as in leave terms and capacity building and productivity focus, and whether the activities are focused to the stakeholders, in this case, the students, the parents, the management, or the owners. So conceptual framework for quality assessment, I'm not going to illustrate, but such frameworks are available, and depending on the purpose, you search for those frameworks, and then it gives information. For example, here it says student evaluation of teaching. That's why there are surveys where students are asked, because they are the stakeholders, they are the beneficiaries, and then the student surveys will elicit information about the teaching, about whether they are satisfied with the teaching or learning that is happening, and then whether they are being engaged by the teachers during their instruction. Then there is a framework for innovation. So if you are in charge of innovations just don't happen on their own. If they are not happening, then they use this conceptual framework to identify what's missing. So several things are listed, and check whether they are happening. If they are not happening, then you plan for them, and that when we plan, the institution becomes innovation receptive institution, and then more and more innovations happen, and as a result of those innovations, the product and output become better. So framework for excellence, role of internal quality assurance cell. So as part of the accreditation organizations, we have a framework for excellence. Step one, for example, this is for curriculum. Review the current curriculum content and pinpoint the skills, knowledge learners should possess at the end of the learning. So this is well-known, documented one. And then finally, where are they? Where is it? The gap identification is critical for quality improvement. So what is the gap between the present state and the future state? And finally, based on the gap identification, you can then plan an intervention. So program evaluation or education research to identify the gap. To identify the gap also, there is need for educational research. And then based on the systematic planning of the innovation and intervention, you need to design the innovation. And then once you have implemented the innovation over a period of time, periodically you have to review and then make changes so that you achieve excellence. So this is a very, innovations are there, but still people are resistant to adopting. And one of the reasons they say is, I am busy. Okay? So the inventor of the wheel is suggesting the busy practitioner, why don't you choose this method of teaching? No thanks, rejection. Anything new, it's difficult. And one of the reasons is busy. Or maybe we are busy but doing the wrong things, or we can't be reaching excellence by doing those things. So one of the, this is the Stephen Covey 4-quadrant framework. Which quadrant are we now? Spending most of our activities. Crisis management, if you don't do the quality time on prevention, capability improvement, relationship building in the staff, recognizing opportunities, planning, recreation, all that quality time is not being spent by faculty or the staff, then the institution will end up with crisis. Only when something NMC sends a warning and takes away recognition, then it's crisis. So pressing problem, deadlines and all, we are busy with meeting deadlines. And some of the activities are simple time wasters and distractors. And so we have to identify, research the current status, what are we, or which quadrant are we spending most of the time, and then based on educational interventions so that the time is productively used by faculty for capacity improvement so that their quality improves. Bill Clinton, when he visited Taj Mahal, he mentioned there are two kinds of people in this world, those who have seen the Taj and those who have not seen the Taj. Of course, I belong to the group that has seen the Taj. Why I'm saying it is because I had the opportunity of going to the most important center, the WHO Center of Excellence in Medical Education, and you all are familiar with the Miller's Pyramid. George Miller was the founder of this Department of Medical Education at University of Illinois at Chicago. So I got this international fellowship in medical education, and it changed my perspective, changed from being a simple teacher to an educationist. So before getting the international fellowship, I spent 20 years as teacher. After fellowship, again 20 years now, plus one more year. So leadership, now I can design based on the need. Again, design. Here it is just implement. Now I am able to, I have a chapter on program evaluation in the books on medical education. Education researcher, educational publications. Now most of the time currently I am mentoring people who are interested in research and doing. So doing it so that they do it the right way, using the right instruments and present what others will value. And that is also possible through building a community. So we are all faculty members or we are students. We have students WhatsApp group. We have a faculty WhatsApp group. So each one, a community of practices is one where the individual members don't hesitate to seek help and give help. So because the common purpose is to excel. For the students, the common purpose is to pass and pass with flying colors. So forming a community, building community is important. So my perspective is think globally, think of the issue, the body that is available, the information is available. Act locally. What is the gap? What is the problem? Start with the local problem. What are the challenges that are faced in the student learning, teaching and all that? Use appropriate conceptual frameworks. Identify the gaps using the conceptual frameworks. And identify the capacity building needs, because without capable faculty or staff, they won't be able to bridge the gap or come up with innovations and interventions. And then design tailor-made interventions and doing it right. We call it the scholarly approach. So there are ways in which, and one of the ways is to use the logic model or the program theory, and then program evaluation, which fits the purpose, and education research, which also methods. Some of us in core disciplines are used to providing or doing only the randomized control trials, but that may not be needed in education research. So simple descriptive studies and doing a qualitative study to identify why is enough. So that is important. and then be a part of a community of practice. Say this is the interest, particular interest groups as part of the curriculum, this accreditation. We have different domains. Within each domain, we can have a community of practice, and then all of us come together. We collaborate, because collaboration is important, because each person has different, distinct abilities. Some are very enthusiastic, some have ideas, some have access, and their strength is use of IT resources, statistical analysis and all. So all those abilities, you join hands. One person alone may not be able to do everything. And also find a mentor, because the mentor will then guide you whether you are going in the right direction. And then publish. So what publication will happen when you package, identify what is it that you have done as part of research that would not only interest people locally, but also outside your institution, because the journal is, your article is read by others. If the item of interest which you have researched is of no interest to others who are reading that journal, then the editor will put it in the dustbin. So what is of value? We need to identify, focus on that, explain in details so that it can be replicated elsewhere by others who are reading and inspired by your research. So that's finally the end. And you're encouraged to ask questions so that we can really learn.
Thank you, dear sir, for that wonderful talk. Frameworks on frameworks. We learned from the framework of medical education. So we students of FAMA, we used to call you the Chacko-versity, sir. It's Thomas Chacko plus a university. So it was evident here, sir. Dear students and faculty, any doubts? Any burning questions that you'd like to ask, sir?
Thank you very much, sir, for that thought-provoking talk. One of the things which you had mentioned to us once was, how do we convert our routine work into a repository where we can probably develop a good database? This is something I've been thinking and trying to implement, but there are a lot of struggles. So could you have any general suggestions and maybe?
Why I had suggested to Dr. Philip was, they are all very busy clinicians, engrossed. Yesterday he was there till 7 p.m. looking after his endocrinology OP. Now that is a constraint, but also an opportunity, because a variety of cases, situations, and the commonalities, and then similar to Archimedes, suddenly when Archimedes was having his bath in a bathtub, he got the idea of displacement and all those things. So you have this eureka moment suddenly, and then ask yourself, what is it that is novel in the way I am doing, which could be of interest to my fellow endocrinologists? Or you have a good nurse educator in the Department of Endocrinology, and she takes of the workload of several different subsections in care provision to the patient. So what works? Do a survey of the patients as an exit interview, and you don't have to do that. You can enter somebody with the exit interview to find out how was the patient encounter by the doctor, by the staff that were assisting, what did they learn, what they would like to improve, and all those kind of things. And maybe you can use some of the conceptual frameworks appropriate to the problem that you feel is a problem. And I can help you with so many frameworks. You tell me what is the problem, and I can help you identifying the appropriate conceptual framework that will guide you. Good question. Anybody else?
So, thank you, sir, for that presentation. You are repeatedly saying busy clinicians. I think in my philosophy is you must never say no time. You must find time. So I think all the faculty must find time to improve themselves and get feedback from students so that we can improve. And that is my suggestion after this talk.
I showed you the two ladders. Are you busy climbing up the wrong ladder? Or are you climbing up? Madam said, prioritize. Everybody gets 24 hours in a day. And it depends on how you prioritize. If you prioritize different activities, you will find time. In fact, the most busy person is the person who gets the priority things done in a good way. Thank you, ma'am. And if you are hesitant to ask, you can always meet me. Or I am in most of the batches WhatsApp group. You can ask either in the group question or direct question to me alone. You are encouraged to ask. Only by asking question, we say a community of practice, you have to ask and seek help. And in the community also, if you have the answer, feel free to share your answers or innovations.
Thank you, sir. Like Abdul Kalam said, I climbed. Where is the wisdom, Lord? Here is the wisdom in medical education. So please do make use of his wonderful expertise and meet him, talk to him, get your research done, get all your frameworks in place. So with that, we come to a close of this wonderful session. Thank you all for coming. Today evening for medical students, we have Dr. Laji, who is the people's physician in the Himalayas. So a very, very interesting personality, someone who has transformed the landscape of medicine in remote areas of the Himalayas, serving people for a few decades. And he's going to talk to medical students specifically today at 5 p.m. So you're all invited for that session. It's going to be here at the amphitheater. And tomorrow morning at 8 a.m. we have a special edition of Quest, which he will be taking again. He will be asking pertinent questions pointed at us, why we are doing what we are doing, what is the purpose of our life, and much more. So I really hope that all of you come over tomorrow morning as well. And today evening specifically for medical students, I'm pretty sure seeing your faces, this hall is going to overflow. So thank you all. Have a wonderful day. Let's end this. Thank you.